Welcome to Podcast 1.
Welcome indeed. We are the medical team at the Virtual Doctors. My name's Fran.
And I'm Minnie.
So we'd like to introduce this series of podcasts which aims to bring medical education to you, the clinical officers, in your setting in the field in Zambia. This is a trial of podcasts, so we'd really welcome your feedback, both positive and constructive, and also let us know if there are any future topics you'd like us to include.
Great. So we thought we'd start by giving you a tip with each podcast, and this podcast tip is to take a comprehensive history. We're really aware that you, the clinical officers, are time pressured and that you're seeing lots of patients, and it can be difficult to know what information is helpful to include in your emails. So making sure a good history is taken from the patient is really vital. As we know, most diagnoses are based on this rather than the examination, which really just confirms what we're suspecting is going on with the patient. So the more information your virtual doctor's case includes, the easier it is for the volunteer doctor to give you an accurate response and good advice for both you and your patient.
Brilliant. And given that that's our first tip, we thought our topic today would be to remind ourselves of some of the basics of taking a good history from a patient. So in medicine, we try to start any consultation with an open question to find out what symptoms made the patient present to the healthcare centre today.
So, Fran, when a patient comes to your clinic, how do you like to start your consultations?
So I try and use an opening gambit. I might say, right, or so tell me what's going on. And then I don't say anything and I let the patient talk.
Gosh, that must be quite difficult.
It is, and particularly for someone like myself who likes chatting quite a lot, I find it quite hard not to interrupt. But actually, research has shown that on average, a patient will only talk for 90 seconds. And in that time, they'll give you a lot of important facts that if you interrupt them and ask them direct questions, would actually take an awful lot longer to gather that information.
And do you think that sometimes makes them lose the flow of what they're trying to tell you in the first place?
Very much so. And I can see that if I do interrupt a patient, that they do that, and that it kind of stilts their conversation. And it's something that we all work on. I know that I've had to work on it, and certainly when I'm training GPs, is just to sit still and let the patient tell you their story in their words, and you'll get an awful lot of really helpful stuff right at the start before you then go on and start asking more direct questions.
Okay, so if the patient is not able to tell you everything, how do you encourage them to keep talking?
So use of body language and words, this sort of encouraging cues. So either sort of nodding your head, saying yes, or tell me more, or, aha, that sort of thing can be incredibly helpful.
Great. And then sorry, I interrupted you and you were just starting to talk about direct questioning.
Yeah. So the one thing that I was going to say that I think clinicians have a habit of doing is using leading questions when they do direct questions. So They would say something like, "You don't smoke, do you, Minnie?"
Oh, no.
Yeah. And then the patient is answering what they think the clinician wants to hear. Yeah. So it's really important that when you do ask direct questions, that you ask them so that a yes or no can be given. So you would be saying, "Do you smoke, Minnie?" for example.
And then I might tell you the truth.
Exactly, yes.
Okay, so maybe we should use a symptom to help us look into the direct questioning more. So if we used a symptom, for example, cough, if that was the main symptom the patient had coming to see you, what sort of things would we want to know about that symptom?
Okay, so I'd probably start with the onset. So when did it start? And was it a gradual start, or did it come on acutely? So a very abrupt start.
Okay. And I suppose that helps you to think about, well, if it was a gradual thing, how long has it been going on for? So you want to know the duration of this.
Yeah, and in medicine, typically we just divide things into acute and chronic. So an acute cough in this instance would be something that had been going on for a few weeks, whereas a chronic cough would be something that had been going on for a few months or more.
Okay, well, that's really helpful to know, isn't it? Because obviously your differential diagnosis would be different for each cause.
Yeah, definitely, and certainly in the UK, patients use those words in a slightly different manner. So it's quite interesting to differentiate that. And then say it is a chronic cough. I'd want to know about the course of it. Has it got better? Has it got worse during that period of time?
And with that, better or worse, have they tried something to help it get better? So you might want to ask if they've been using any medications, been given any medications from family, friends, or a local healer, for example.
Yeah, yeah. So
That might
I'd
be
call
useful.
exactly. So I'd call those relieving factors, and then on the opposite side, sort of precipitating factors. So things that had triggered the cough off. So maybe some exposure to smoke or going out in the cold or something like that.
Okay, so those are your triggers, precipitating factors.
Exactly. Yeah.
Okay. We also want to know how bad this is, don't we? How severe the symptom is for the
Uh
patient.
huh. Yeah.
So, for example, with cough, you might want to find out how it's affecting their daily lives. So, is it causing them to feel breathless? Is it giving them pain? Is it waking them up during the day or night? Are they able to do their usual job, walk around the house, that sort of thing?
Yeah, fantastic. And then going on from all these symptoms, we'd look at sort of associated features that the patient may have with the cough. But we're going to talk a little bit more about that in another podcast where we talk about a sort of systemic inquiry where we look at the body as a whole and would be asking about sort of weight loss and night sweats and stuff.
Okay. But that's still important to ask about and to get negative responses as well as positive to the questions that you
Absolutely. Yeah.
ask.
Yeah, no, absolutely. And then finally, I would be asking about previous episodes, Minnie. So
Okay.
is this a recurrent thing that they get, every rainy season, or
Okay.
so you might be thinking about asthma with something like that. Yeah.
Okay. Thinking about asthma, that's obviously something they may have had in the past. So that would lead us nicely into thinking about past medical history. So we'd want to know if the patient has had, say, tuberculosis in the past, asthma, as you've mentioned before, other medical conditions which could affect their respiratory tract. Are they diabetic? Have they got HIV?
Yes, absolutely, and particularly in Africa, where unfortunately the incidence of HIV is so high, and we know that it's linked to so many respiratory conditions. I think that's, and not just whether they are HIV positive or negative, but whether they've actually had a test, because it
Ever?
may be that, it may be that they don't know their status. And then of course asking about their drug history, what medicines, you talked about this before with sort of relieving factors, what medicines are they on that either they're trying for the symptom of a cough in this case, or what medicines are they on that possibly the side effect is the cough. So we know that with ACE inhibitors, drugs such as enalapril, that a dry cough is a side effect of that, which somewhat sneakily can appear at any time when you're on it. So it doesn't necessarily start when you start the drug. It can begin a couple of years into the medication.
Well, that's interesting to know. So it's important. The drug history is always important.
Yeah, and as you mentioned before, Minnie, it's not just medicines that they may have got from the healthcare centre. Are they taking medicines from a healer? Are they buying things over the counter? Are they asthmatic and they're taking aspirin, which could be triggering a wheeze, for example?
Okay. Other things that might trigger wheezes, that makes me think of allergies. We need to find out if the patient has any allergies.
Yes, of course. And in the UK, it's very common to be allergic to sort of nuts and dairy, particularly in children. So we'd be looking out for things like that.
Okay. Thinking of children, that we need to find out about the situation at home for a lot of people, what their job is. Are they in jobs that expose them to chemicals or dust or, in farming. So those things are important for us to ask too.
Yeah. And also their housing conditions, with you mentioning children, are they living in an overcrowded house where perhaps one member of the family has TB, or even one member of the family is smoking? And so smoking history, not just in the patient, but in the family, is really important, because passive smoking can have such impact on respiratory health, unfortunately.
Yes, so that's an important question, and something that you can refer back to when you see the patient again to see whether they're smoking more or less even.
Absolutely. And I think it's really important to pin people down on how much they are actually smoking, because very often with these things, and we'll mention alcohol and recreational drugs, people very much underplay the amount that they are actually taking these drugs.
So just going back, Fran, if we just summarise, or if you could just summarise how we're going to do this history taking from about the main symptom, what are the core things that we need to be asking?
Okay, yeah, brilliant. So we'd be asking about the onset of the symptom, its duration and its course, whether it's got better or worse, how severe it is, any precipitating or relieving factors, any previous episodes where they've had it, and any associated features, which again we'll go into in a future thing. And then we'd, just to summarise the other relevant factors we've mentioned, past medical history, drug history and allergies, social history, and then smoking, alcohol and any other recreational drugs, things like marijuana, which they may be reluctant to talk about. And then finally, we didn't quite get around to mentioning contact with any animals or pets, and family history, particularly important in things like asthma, where we know, and TB, of course, where we know that there's an increased risk for the patient.
That's great. Thanks for summarising that, Fran.
Very welcome. And thank you, everyone, for listening. And we hope you've enjoyed our first podcast, and look forward to seeing you at our second one. Thank you.
Bye-bye.